All right, good afternoon, everyone. So I'm Professor Darlene Riggs, and I wanted to take an opportunity today to just share with you a way that helps you understand the antibiotics. So the purpose of this session is to really decode antibiotics. So what happens is often students will, memorize drug pathogens or just try and remember, the drug for the infection. And that doesn't work very well when the question is looking for your critical thinking. Okay. So it's fine if it's a easy, knowledge comprehension question, but it's not that simple when it's a question that has to do with critical thinking. Okay. So I built this, and I'm also going to lecture this as if you were driving and listening to me. So if you're not driving and you're actually looking at the PowerPoint, you're going to hear me speak a lot more than I really need to. But this is really for folks who are also driving or podcasting, listening to me while you're walking, and multitasking. But I would suggest you listen to this again or go through it again when you're able to stop and process instead of just, listening and multitasking. So the way I like to help students understand this is by what I call, the 8 classes. So generally, the medication will fit under, one of these 8 classes based on the area of the body. I'm going to peel these one by one. So let's start with this one. So the 8 classes is what I use, and it's a way of helping students with process of elimination. So it's a way of eliminating the antibiotic that is not correct and getting to the correct antibiotic for the infection. So keep this in mind. And by this, if you're not, using the PowerPoint to look this up, I have a PowerPoint up here that separates the beta-lactams, which are the penicillins, which is the aminopenicillins and inhibitor, which you better known as augmentin, and the cephalosporin. So those top 3, okay, penicillin, augmentin, cephalosporin, are what we call the beta-lactams. Why? Because they have a cell wall, okay? And then number 4, 5, 6, 7, and 8 are your macrolides, tetracycline, fluoroquinolones, sulfonamides, and some site-specific specialist drugs that don't really have their own category. So I do recommend you work these from top to bottom, and I will show you in a moment. So when the rung above is disqualified, right? Let's say 1 is disqualified due to allergies. You're going to go to the next one. And if the next one is disqualified due to resistance, then you're going to go to the next one like that. So I do have here for you both brand and generic names, but you need to focus more on your generic names for test purposes. But they're all here. So keep this in mind, and I will be, referring to it and bringing it up again and again, because that is what I would like to call the cascade, right? If you drop one domino, it should drop the others until you get to the correct medication. So by the way, so 1, 2, and 3, penicillin, augmentin, cephalosporin are beta-lactam. There's a cell wall. And your category 4, 5, 6, 7, and 8, there's no cell wall. That's going to make sense in a moment, okay? So keep that in mind. To go back again, for those of you who are listening, your penicillins, we're talking, penicillin V, amoxicillin, ampicillin, you hear stillin, stillin, so your penicillins. Your aminopenicillin and inhibitor, that's augmentin, so that's a combination drug. Obviously, it has amoxicillin and clavulanic. That makes it, augmentin. Now, anyone allergic to penicillin, especially if it's an anaphylactic allergy, then you wouldn't give them augmentin either. And your cephalosporin, those are cephalexin, which is the first, generation. That's Keflex, you're familiar with. And the other, so you see cephalexin, SCP, versus Ceph. The others are Ceph, like cefuroxime, cefdemir, ceftriaxone, okay? And a lot of this, if you're not familiar with the generic, you're probably familiar with the brand name, like ceftriaxone is Rocephin. If you're, at the bedside, you giving that, especially if you on a unit where like an infectious disease unit, you're giving those, frequently. All right, so those are your beta-lactams, okay? They attack cell wall of the pathogen. So they would be for pathogens with cell walls. So now your non-beta-lactams, no cell walls, are your macrolides, okay? That's your azithromycin, clarithromycin, erythromycin. You hear it, mycin, right? And your tetracyclines, those are doxycycline, minocycline, cyclin, hence the name tetracycline. So find little ways to remember these. I think penicillin is pretty simple because cephalosporins, not so much, but the beginning, the prefix help you instead of the suffix with the cephalosporins, right? Sep. And your macrolides, find a way to remember that your macrolides are the ones that end in thromycin, right? Thromycin. So when you see thromycin, you'll know that's a macrolide, and that's number 4 on our list. And your tetracycline, that helps you to remember that's the tetracycline family. Now, fluoroquinolones are a little bit special. The suffix for these are floxacin, ciprofloxacin, levofloxacin, okay, moxifloxacin. So maybe the prefix with this one, fluoroquinolone, right? So that's the best we can do with that one. Sometimes it's not perfect like that, but you've got to figure out a way to know the moment you see ciprofloxacin, you know that is the fluoroquinolone family, okay? That's really what you should do on your own time when you're processing all of this. Now, your sulfonamides, so a special drug that falls under that umbrella is your Bactrim, okay? Sulfamethoxazole, trimethoprim. So that one is very unique. The other thing you need to remember too is allergy to sulfa when it comes to Bactrim. So the moment you hear somebody has that allergy, get rid of that drug from the list, okay? And there are some site-specific ones like nitrofurantoin, which you're familiar with, macrobid, especially for uncomplicated UTI. And under that umbrella, also clindamycin. Often when we're ruling out, antibiotics for other reasons, we may end up giving clindamycin because all the others have been ruled out for one reason or another. And metronidazole, flagyl, for like some of your sexually transmitted infections. Yeah. So that's what I like to call your cascade. So keep this one in mind. We'll refer to it again and again. So now this slide or this table helps find the trigger in the stem. So that's the thing. You have to pick up on clues that helps you eliminate certain antibiotics, right? Find the trigger in the stem, then walk the ladder from earlier that I showed you. So if the client has a penicillin allergy and it's a rash only, meaning it's a non-anaphylactic, right? Their area was not closing down on you, then you can, give a drug from that family. Okay, you can start with a cephalosporin, okay, but not, penicillin or augmentin. It would be safer to start them with a cephalosporin, okay? So cephalexin, Keflex would be great. Cefdemir, Omnicef would be fine. If for some reason, you cannot go with cephalosporin, then go down, right, the cascade to your macrolide, okay? Then go through to a azithromycin, okay? So if you go back, you see here, you can't give a cephalexin for whatever reason. Let's say that community, is resistant, then it has resistance to it, then you would go to your macrolides. That's the next one, okay? So that's kind of what I'm teaching you, so that way you'll know how to get to the correct answer, okay? So we wouldn't use the penicillins in that case if they have a penicillin allergy, okay? Now, if it's a penicillin allergy, that is definitely anaphylaxis, right? Or angioedema, then we definitely want to stay from the entire family, the cousins, twice removed, all of that. So go straight to a macrolide, okay? Skip all the penicillins, okay? 1, 2, and 3, skip all of them if it's a true anaphylaxis or angioedema allergy. Okay, so macrolide would be next in the list. If for whatever reasons, resistance, something else, they're not able to take an azithromycin, then you're gonna go to your doxies. Okay, doxycycline, clindamycin. So if you look at your cascade again, so they cannot have any penicillin, so that means no 1, 2, or 3. For whatever reason, they can't have a macrolide, then your next one is 5. You ruled out 1, 2, 3, 4. So we go to our tetracyclines. Okay, so that's really, I'm hoping as we do this, even from only 3 examples, you get the gist, you get the point. Okay, so we wouldn't use the beta-lactams. There's no cell walls with those. So next one, MRSA, methicillin-resistant Staphylococcus aureus. So the moment there's purulent drainage, we go MRSA, okay? If the client says, had a spider bite and there was no spider, we go to MRSA, okay? Typical description. So for MRSA, you just really need to memorize these 3, BCD, okay? So B for Bactrim, we go to Bactrim for MRSA, okay? C, clindamycin, and D, doxycycline, and really in that order. So if for whatever reason they can't do Bactrim because of allergy, then go to clindamycin. If for whatever reason they can't do clindamycin, then you go to doxycycline. Okay, no beta-lactams work with MRSA. So get away from 1, 2, 3. Okay, so that makes it easy, right? Now, your beta-lactamase producer, like H. influenza, there's another slide I have for you to explain that as well. So with your beta-lactamase producers, go straight to augmentin, okay? And if that doesn't work, then you go to your cephalosporins, okay? Your anaerobes. So again, I have another slide that's going to explain those, just a refresher for those of you who've forgotten with the gram-positive versus gram-negative versus the anaerobes. And yeah, so like with a dog bite, go straight to your augmentin, okay? So your beta-lactamase producers, H. influenza, your anaerobes, augmentin, 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 okay? If it's beta-lactamase producer, that doesn't work, cephalosporin. If we're talking a dog bite, animal bite, and for whatever reason we can't use augmentin, allergies, whatever it is, then we're gonna go to clindamycin, okay? Your uncomplicated cystitis, then, if it's lower, no fever, negative CVA tenderness, then you're going to go straight to your nitrofurantoin, okay? Your macrobid. So if there's allergies, or we're dealing with a complicated UTI, then you're going to go fluoroquinolone. But we always say fluoroquinolone for last measure, severe. You're never going to go to a fluoroquinolone first, because look, if you go back to see, oops, it's number 6. So by the time you get there, unless we're talking a non-complicated UTI, you have a lot of options. Okay, so keep that in mind. Don't forget, read in your questions. I have that repeated in this lecture so that you remember, pay attention to age, pregnancy, allergies, resistant, right? All of these things you want to keep in mind. History of tendon, issues. You'll see why, in a moment. So those are the things that the moment you see them in your question, some of these antibiotics are out. You're not going to be using them, okay? So now, this is what I'm talking about here in this slide where I title it signature warnings, okay? And it's good to even keep these in mind in the order that they're in. I find it easier to keep it in that order. Other students have shared that as well. So I have, again, penicillin, augmentin, cephalosporin, macrolide, tetracyclines, fluoroquinolones, sulfonamide, and site-specific specialist drugs. So for your penicillin, again, you always want to ask questions to your clients. You're allergic to penicillin. What happened when you were given penicillin? I want to know the type of allergy was. Now, if they tell me, yeah, I had to be hospitalized, couldn't breathe, so we know it was a true reaction. So we want to know the type of allergic reaction that they had. Was it a type 1, reaction where they had, their laryngospasm, the throat's closing up, angioedema? If it was a rash, then we can, play with the cousins. So with the mononucleosis, there's a test question with that one. So you see I have here rash if amoxicillin was given during mononucleosis. So we want to know that too. So we won't use penicillin if it was a true penicillin allergy, or if there was, mononucleosis after an amoxicillin was taken. So those things you need to keep in mind. Your category 2, your aminopenicillin with the inhibitor. So your augmentin. So signature warning. High risk for C. difficile, Clostridium C. difficile. The C stands for Clostridium. So they get that diarrhea that has that unique smell that you won't forget it when you smell it. It sticks to your memory for some reason. So diarrhea and C. diff risk. So high dose amoxicillin components are needed for drug resistance, which we have quite a bit of that, but if that's the drug we have to use, they're at risk of the C. diff. So you need to keep that in mind. So we won't use augmentin either if there's a true penicillin allergy or if they've had a prior experience with C. difficile. So that's for number 2. Number 3, your cephalosporin, those have cross-reactivity with penicillin. So it's like a cousin is a good way to think about it. But that's higher with your Keflex, with your first generation versus your second or third, okay? And if they had an anaphylactic reaction with any penicillins before, then you're going to stay away from that whole family, okay? Macrolides. So with macrolides, if your question, we have EKG and there's a QT prolongation or cardiovascular death risk, or history of, you're going to stay away from the macrolides. Okay. And if the client is on Coumadin warfarin or digoxin or any statins, okay, that's not the drug for them. Okay. So we're not going to use any macrolides if there's a history of myasthenia gravis. Again, we have an EKG with QT prolongation, or we do a medication reconciliation and we see warfarin, digoxin, a statin. Yeah, nope. Get rid of the macrolides. Okay. Number 5, the tetracycline. If the person is pregnant, okay, big no, because the teeth staining for the unborn baby. Photosensitivity, esophagitis, right? So we teach with the tetracycline family as well, take it with a full glass of water and remain upright. That's how we prevent that esophagitis that they're at risk of. And tetracyclines are not approved for children under the age of 8. That's why I tell you, pay attention to age, right? Young, old, pregnancy, of course, allergy, resistance. You've got to keep these things in mind, okay? I give you a question and I put that there's QT prolongation. You've got to wonder why and what drug family does that eliminate, okay? Fluoroquinolones, number 6. Black box warning. History of tendon rupture, tendonitis, no fluoroquinolones. Peripheral neuropathy, No fluoroquinolone. Central nervous system effect, hypoglycemia, QT prolongation, again, aortic aneurysm. Okay, so these we would only use fluoroquinolone, like I mentioned earlier, right, if the pros outweigh the con. And we would have to weigh that to see, right? Because, ooh, tendon rupture is not a fun thing, right? If I give you this question and tell you it's a teenager or they're 16, you are not going to give a fluoroquinolone. They're pregnant, you are not going to give a fluoroquinolone, right? Myasthenia gravis, history of prior tendon injuries, right? Eliminate all these fluoroquinolones. Okay, you see when we start with, the macrolides, the tetracyclines, the fluoroquinolone, there's a few things you need to keep in mind. Number 7, sulfonamides. Sulfonamides, I want to pull the electrolytes. I want to see what the potassium especially is doing. I want to pull the creatinine level, right? Because the client is at risk of hyperkalemia and a rise in their creatinine, okay? And Stevens-Johnson syndrome. So if you see sulfur allergy, okay, remove the sulfonamides. Okay. 3rd trimester, no sulfonamides. They're on warfarin or ACE inhibitors, or they have chronic kidney disease, right? Because of the rise in the creatinine. Get rid of the sulfonamides. That's not the drug for this client. So keep these in mind. Site-specific ones, your macrobid. So the big deal with nitrofurantoin, the macrobid is that it does not penetrate the tissue, so it will only take care of a lower urinary tract infection, a non-complicated UTI. It wouldn't work, for pylo. Yeah, so if that's what they have and you give it, it's like you didn't give anything. You might make them worse, if anything. So clindamycin, C. diff, we mentioned earlier, Clostridium difficile. Your nitronidazole, Flagyl. We always educate, never take Flagyl with alcohol, right? You are at risk of disulfiram reaction with alcohol. So similar teaching that we give, recovering alcoholics not to ingest any type of alcohol when they're on disulfiram, because it's just horrible, feeling. They get extremely ill. So history also of pyelonephritis or prostatitis. Creatinine clearance less than 30 is a no. Okay, none of these drugs. No alcohol at all. Alcohol, period, with any of these, but specifically your nitronidazole, Flagyl. So those are some signature warning. So now we're going to get into, each specific family and where the pathogens are and why you would use, that antibiotic. So how to use this PowerPoint is another thing you want to keep in mind. I'm really telling you this verbally because it doesn't make sense to memorize 100 drugs. And so the antibiotics, feel a little bit chaotic until you organize it the way I'm showing you to organize it, because there are just too many. So if you classify everything by these 8 categories, it really does help make this a little bit easier, knowing what to choose to treat the condition that you're dealing with. So work on this. Now, there's 4 what I call question chain to keep in mind whenever you're dealing with an antibiotic question. So you want to run this each time. Number 1, ask yourself, where is the infection? I'm going to go over that next. Okay. The site of the infection is going to predict what pathogen, would be in that area. So you want to start there. So the anatomy alone, is it the skin? Is it an ear? Is it a lung? Is it, the throat? Where is this infection? So the anatomy narrows the field where you name a single organism, okay? So the next 2 slides I'm going to go over will map out, the common body sites and the organisms found there. Okay, so that's what's coming up next. So where is the infection? And then what pathogen lives in that area? Is it usually gram-positive, gram-negative versus atypicals versus anaerobes, or is it methicillin-resistant Staphylococcus aureus? The site is going to tell you. That's step 2. Step 3, which class from the 8 classes that we just went over earlier kills this pathogen, right? And reaches that tissue and annihilate this pathogen, okay? Penetration matters. If it doesn't penetrate it, it's never going to kill it. So a drug, as I write here, a drug that kills the pathogen in the dish but can't reach the site, okay, is still the wrong answer because that's a temporary fix. And a great example of that is with UTI and nitrofurantoin, macrobid, okay? That's a trap. So what disqualifies, your first option? Pay attention to that. Either an allergy may disqualify that choice, being pregnant may disqualify that choice, the age, right? Are they a 6-year-old, 7-year-old? Medications we don't give unless the child is at least 8 years old. Are they 17 years old? Because there's medication where 18 is the cap. Yeah, so you want to ask that question. Renal function, what goes in must come out, right? Cardiac function, tendon risk, drug interaction. These are questions you ask, and based on the answer, you are able to remove some medication options, okay? So where is the infection? What pathogens live in that area where the infection is? What class of medications killed that pathogen? And are there any disqualifiers? Okay? All right, so now part 1, where is the infection? Is it in the soft tissue, the skin, right? If it is, those are usually your gram-positive, cocci like Staphylococcus aureus. And don't forget, when we're dealing with staph, is there purulent or non-purulent? If it's purulent, then it's MRSA until proven otherwise. Just the way that is, okay? Is it a group A strep, right? Non-purulent, then that's your strep, right? Versus your staph. So don't mix those two, okay? Non-purulent is most likely strep, group A strep. Purulent is most likely Staphylococcus aureus, okay? So you remember your non-purulent, right? Your strep, we're going to use our cephalosporins, right? Like cephalexin. If it's purulent, remember our little mnemonic, BCD. Okay, we'll go over that again. I repeat things a lot so it sticks to your long-term memory. Now, let's go across. Let's say it's the throat and the pharynx. So that's most likely your gram-positive cocci, group A strep. Again, strep pharyngitis. We do a rapid strep swab, okay, for those. So if there's no contraindication, no allergies, we can treat those with penicillin. Okay, if there's penicillin allergy, then we go through to the azithromycins. Okay, now let's say it's the ear and the sinus. Okay, your upper respiratory. So it could be gram-positive cocci or gram-negative. So if it's gram-positive, most likely Streptococcus pneumoniae. Okay, your otitis media, sinusitis, right? We palpate, very tender, could have a fever. Your gram-negative Haemophilus influenza, that's beta-lactamase producers, okay? So you see how I'm repeating this information so it sticks to your long-term memory. Beta-lactamase producers, and you know what that means now. Gram-negative cocci, Moraxella, catarrhalis, beta-lactamase producers, okay? So we're going to go with our amoxicillin, okay? If that doesn't work, then we could go augmentin and then down to our septamine, so a ladder, okay? It's a good way to think about this as a ladder. Your next one, lungs, the typical pneumonias. So gram-positive Streptococcus pneumoniae are those classic community-acquired pneumonia type of cases. Your gram-negatives are your Haemophilus influenzas, like for COPDers and smokers. So those would need high doses of amoxicillin, okay? Or we could do ceftriaxone and then down to our level fluoxetines, Of course, that's never going to be first option. We got to get down to that point. Your lung atypical walking pneumonia, okay, atypical. So keep that word in mind. So under that umbrella, those pathogens, there is no cell wall, okay? Whereas you saw with the ear and sinus, where's my cursor? Right here, ear and sinuses, we had the beta-lactam. There was a cell wall. So we can do the amoxicillins and the augmentin, but with the lungs and the atypical walking pneumonia, there is no cell wall. So if you give penicillin, it's not going to do anything. There's no cell wall to fight. Okay, so that would be your azithromycin, your doxycycline, your levofloxacin, because those, they're not looking for a wall to attack. Okay, so hopefully this is making sense. So your atypicals are Mycoplasma pneumoniae, Chlamydophila, and Legionella. Okay, so walking pneumonia, of course, respiratory, and pneumonia that has systemic symptoms. Okay, for your meningitis and your central nervous system, where's my cursor? There we go. And for your central nervous system, let's go back. It's going to be your gram-positive Streptococcus pneumoniae. That's the leading cause, adult cause. Okay, and your gram-negatives are the Neisseria and the Haemophilus. Okay, so like your teenagers who go off to college, they're more prone for the Neisseria meningitis in the dormitories, close quarters, lots of people type of environment. So they need to be vaccinated. Your unimmunized children, yeah, they're at risk of the Haemophilus influenza. So for those, it's going to be ceftriaxone, okay, Rocephin. And the issue with these, they cross the blood-brain barrier, so they should be taken seriously. So that's step one. Where is the infection? Okay, are we talking skin, soft tissue, throat, ears, sinuses, lungs? Okay, with the lungs, are we talking typical pneumonia or atypical pneumonia? Okay, typical pneumonia has a cell wall. Atypical pneumonia, no cell wall. That's the difference between those two. So you need to know, so you'll know what medications will work, right? Typical Streptococcus pneumonia, amoxicillin. Atypical, okay, you cannot use penicillin for those. We're gonna go to the azithromycins. So you'll have to spend a minute on this slide. I would recommend it. It's not something you see one time and then boom, you got to look at it over and over again and make it make sense. So now we've got the where is the infection? So let's just do a few more. So in addition to the skin, the throat, the lungs, the ears, differentiating between typical and atypical with the pneumonia, the meningitis, we have the urinary tract infection, which again, this is repetition. So that would be your E. coli, okay, and your Proteus. So those are your gram negatives, okay? So macrobid, again, is your first choice, but we do want to, make sure that their kidneys are functioning beautifully. All these, whenever you put folks on antibiotics, you should do that, especially strong antibiotics. So pay attention with the UTI, whether it's complicated or uncomplicated. That usually, deviates you to what medication you're going to use, whether it's a simple or complicated UTI. So if we're talking GI tract and abdomen, that's your gram-positive, your Clostridium difficile. So those you do want a broad spectrum, right? So we can wipe out. But remember, whenever we're doing broad spectrum, we're killing everything, right? So you need to replace those good floras, those normal floras. So they need a probiotic after that antibiotic. Your anaerobes, remember, they live in the gut. They don't need oxygen, remember? So intra-abdominal abscess. So those definitely are the metronidazole, like Flagyl. If we're talking intra-abdominal, augmentin, okay? And don't forget the probiotic post. If we're talking mouth, bites, aspiration, then your anaerobes, again, are great for those conditions. Your streptococcus, mouth GI, again, imagine dark area, very little oxygen. Prevotella, mouth, dental abscess. Okay. And rarely you'll see animal bites and questions about those, but just keep that in the back of your mind. So those would be definitely treated with augmentin and clindamycin. Those are your options. Your genital tract and STIs, okay, sexually transmitted infections, your gram-negative Neisseria, gonorrhea, chlamydia, treponema, and the Prevotella. All right, so we're talking for gonorrhea, syphilis, ceftriaxone. There's something about syphilis that crossed my mind. I'll share that in a moment. I think I have a slide on it too. So with Neisseria, gonorrhea, ceftriaxone, Rocephin, chlamydia, atypical, right? We go back to the atypical chlamydia. That's the azithromycin, okay? 1 gram orally one time. One time is great. Your syphilis, with syphilis, my goodness, so many test questions just flowed through my mind about syphilis, primary, secondary, tertiary. So anyway, with that, another special group, there's a bit more you need to know about syphilis, but I'm just going to cover the drugs here so I don't go off teaching about that. But your anaerobes, we're talking female genital tract. So different family, so pay attention to where, or what STI we're talking about, because depending on the STI, the medication is different. There's a test question with syphilis that's crossing my mind, but okay. Hospital wounds and moisture. So for those are the Pseudomonas. So vent clients, burn clients, the wet stuff. Otitis externa also falls under that umbrella. So those require a cocktail, for the lack of a better word. Instead of just one medication, you want to treat with these three, ciprofloxacin, okay, Zosyn, Fortaz. So it's one drug, and a lot of this is due to resistance. As you know, these pathogens are extremely intelligent. Now, there may be some, outdoor exposure where the client gets a tick bite or something like that. So that's that section right here with the spirochete, okay, Borrelia, Leptospira, and Rickettsia. So like if they come from the mountain, or woods, so there's a risk of Lyme disease, Rocky Mountain spotted fever. So that's going to be your doxycycline, okay? And for the tick bites, you always want to ask, when around the time this could have possibly happened. Because if we're talking less than 48 hours, you don't need treatment. Is if the tick have been attached for a good, 48 hours type of thing. But again, I'm going into the teaching. Let me stick to the medication. All right, so that's a lot, right? So we went over skin, throat, ears, sinuses, lungs, typical versus atypical, meningitis, central nervous system, UTI, all of the GI tract, abdomen, STIs, bites, hospital, outdoor. So that's a lot. Again, you've got to spend time with this. So your organism map, just to recap, your gram-positive, there's cocci and rods. This should be a review again. That's why you have to pay attention to your prerequisites, because a lot of this you did in your, microbiology class, which probably was forever ago. But that's why you have to build on top of, the knowledge that you gain. And that's why you have these prerequisites that helps you have a strong foundation. So with your gram-positive, they have a thick cell wall. They're the ones who stain purple. They have that cell wall. You see the beta-lactam again. So you need the antibiotics that are going to attack that wall. So that's your cocci. You're talking your Staphylococcus aureus, your Streptococcus pneumoniae, group A and B strep. So again, we treat those with penicillins and cephalosporins, but if it's MRSA, there's purulent drainage, then we're talking Bactrim, clindamycin, and doxycycline. So you need to remember that. Your rods, we're talking C. diff in the GI tract, common post antibiotic, especially broad spectrums. So, and don't forget, a little silly test question with C. diff, you need to wash your hands. That alcohol foam doesn't work on killing those. You need to literally soap and water and wash your hands. All right, your gram-negatives, the gram-negative cocci are the Neisseria, meningitis, or your gonorrheas. Your rods are the Haemophilus influenza, Moraxella, Pseudomonas, and your E. coli, enterobacterial. For like your UTI, your gastrointestinal stuff. So pay attention again and go through the cascade. So for those, like example, you would treat, your H. influenza and your Catarrhalis, which, we're talking the beta-lactam producers with augmentin, cephalosporin. Your E. coli and protease UTIs would be with the nitrofurantoin macrobid. Your Pseudomonas, remember, we want to treat those with a cocktail. It would be like your ciprofloxacin, Fortaz. So pay attention, to the pathogen and even, where it's at. So now, there's some special pathogens. So we just went over gram-positive and gram-negative cocci rods. So now your special organism, there's atypical anaerobes and spirochetes, right? Your atypicals, no cell wall. Okay, this should be drilled already, even from this one little session. No cell wall. So forget options 1, 2, and 3. Okay, go straight to your azithromycins and then make your way down. Your anaerobes, no oxygen, right? The bites, the aspiration, the GI tract, okay? Deep in your gut. Imagine, very dark there, no oxygen. So clindamycin, okay? Flagyl, augmentin. For your spirochetes, okay? Syphilis, Lyme disease, you want to go to your penicillin, okay? If we're talking, with syphilis, especially penicillin, 2.4 million units, IM injection, done. Lyme disease, doxy, okay? So pay attention with this whole cell wall or no cell wall. That alone tells you what direction and what antibiotic you should be heading towards, okay? So this is gonna seem like a broken record, the way I cover this, the repetition. So here we are with option number 1, the penicillin. What do they cover? What do they not cover? What are some of the signature warnings, right? So let's go. So penicillin, we're talking penicillin V. I give you both brand and generic names, amoxicillin, amoxil, ampicillin, penicillin, dicloxacillin, Dynapam. So what do they cover? They cover your gram-positive, your oral anaerobes, your MSSA, sensitive, okay, methicillin sensitive, Staphylococcus aureus, not methicillin resistant. Amoxicillin, classic first line for acute otitis media. That's the AOM there. So that's what it covers. What does it not cover, right? So go to the other side. So again, you're going to need to spend time, with these slides. What I'm doing here, I believe will be helpful, but you're not going to get this, with one time, wham, bam, thank you, ma'am. It just doesn't work that way. So repetition, again, this is great start, but please, please, please spend some time, with this. All right, so signature warning. What type of reaction? If they've had a penicillin, reaction, ask. We want to know, okay? Because if it was minor, then we know, okay, we can, try some things. If it was major, then we know this is not for you. You're truly allergic. Let's move on to something else. So board trap. In other words, questions that there's something in the question that gives you a clue that you need to pick up on, right? So this is a nice little, this is not a mnemonic, but it should help you. No cell wall, no beta-lactam. No cell wall, no beta. Starts the same. Okay, so if it's like atypical pneumonia, that's never a penicillin insert. Go down your ladder. Okay, if it's a true penicillin allergy, do not give anything penicillin. Okay, your augmentin, which is a combo drug I mentioned earlier, so it's gonna cover your, everything that penicillin covers. You can go to an augmentin. Okay, your anaerobes, your H influenza, but it won't cover MRSA. Okay, and there's a whole list here for you of stuff that it will not, cover. So study this to where you're understanding, not just memorizing. Okay, you got to know the why. That's why I just spent time with all these other slides. Signature warning, C. diff. You see what I'm telling you? I sound like a broken record. Board trap. So go to augmentin. Okay, augmentin is the answer for animal human bites. And don't forget human bites, you also, pulling the hepatitis, because I'm just imagining it. That's why it's like comical, but it does happen. So you want to, get some extra, blood work, hepatitis B, and test for some other things if it's a human bite, which sounds surreal, but yeah, it happens. Augmentin is a pretty popular, medication that you'll get questions on, so don't ignore this drug. Your cephalosporins, be familiar with first versus second versus third generation when it comes to the cephalosporins. So Cephalex and Keflex, remember that one? That's a first, generation one, first line two. So work your way down, to this one with the allergies. And sometimes, the question could get a little bit complicated to where they add whether there's resistance within the community. You got to pay attention to that as well. So anyway, what does it cover? Your first generation gram-positive skin strep MSSA, okay, the sensitive. High gens broader to gram-negative ones, your ceftriaxone third generation, great for gonorrhea, pyelonephritis, not, lower UTI, pyelo, and of course your meningitis. Does not cover MRSA, okay? Remember, 1, 2, and 3 does not cover MRSA. Okay, does not cover your atypicals, does not cover your enterococcus. They do not. Okay. Signature warning is with the penicillin allergies. If it's a true penicillin allergy, remove your cephalosporins. Okay. The other thing to pay attention, whether we're dealing with upper versus lower. So yeah, those would be some clues in your question that tells you which direction you should be going. Okay. Your macrolide, that's your azithromycin, Zithromax, your clarithromycin, Biaxin, so on. They cover your atypicals, okay, mycoplasmas. Remember, we're not worried about cell wall at this point. There isn't one. Gram-positive, pertussis, does not cover MRSA, okay? That does not cover PARP, does not cover MRSA. But remember, with the macrolides, we need to pay attention to the cardiac with the QT prolongation. What other medications are they on, like digoxin? So there's some signature warnings there, okay? Some question traps. Azithromycin monotherapy for community-acquired pneumonia is always wrong where there's resistance, because it's just not going to work. There is resistance. So you want to add another, right, antibiotic that isn't resistant, okay, to that area. So that's why I'm saying sometimes you got to pay attention to that within your question. in order for you to be successful. Okay, and then again, we want an EKG and take a look at what the QT prolongation is. Number 5, tetracyclines. That's your dicyclines. You know, those are easy in terms of IDing them because they end in cyclin. They cover the atypicals, the community-acquired methicillin-resistant Staphylococcus aureus, MRSA. They cover your Lyme and, you know, even your acne, your chlamydia, wide range, right? They don't cover strep A. So if there's no purulent, this is not the drug. Okay. Signature. If they're pregnant, this is not the drug for them. Okay. Signature warning. If they're under 8 years old, staining up the teeth. Okay. Photosensitivity, esophagitis. So there's education with that one. A little board trap here, a question trap. Doxycycline plus a summer outdoor type of question, photosensitivity. Okay. Educate. Don't go out in the sun between 10 and 2 o'clock. Wear the, yeah, wear your sombrero. Just stay out of the sun, period. Yeah, the whole pregnancy is usually where they aim with this one, but you never know. Your fluoroquinolone. Again, fluoroquinolone is going to be one of those last options. You got to go down 1, 2, 3, 4, 5, you know, before you get to this one. So it covers your gram-negative, pseudo. It covers your gram-positive, your atypicals, otitis externa. It doesn't cover your S. pneumoniae. Okay, so, but it has black box warning, hence why it's like at the bottom of the list. Tendon rupture, right? Neuropathy, hypoglycemia, what's their age? Are they pregnant? History of myasthenia gravis, QT prolongation. Yep. So any of that, this is not the drug for them. Or you have to weigh the benefits, you know, the pros and cons with this. So, and those are your board trap. They'll put that in the question and you have to automatically say, okay, get rid of the fluoroquinolones. Okay. Any of your fluoxetins. All right, your sulfonamides. So Bactrim covers community-acquired MRSA, uncomplicated UTI, okay? That's a test question that, you know, is loved to be asked of you. Doesn't cover group A, doesn't cover atypical, doesn't cover pseudomonas, does not, okay? I want to know what the electrolytes are doing on this drug, making sure there's not another drug that is holding on to their potassium because they're at risk of hyperkalemia with this, or what was their last creatinine level. So all of that needs to be taken into consideration. So again, this is repetition. Board trap, Bactrim in a patient that's on an ACE inhibitor. Again, that potassium holding medications, I want to be cautious. Or they have chronic kidney disease. What goes in must come out. If the kidneys aren't working properly to remove it, how is it going to be removed? It cannot. So that's a problem. Of course, sulfur allergy, this is not the drug for you. Okay. Your site-specific ones. So that nitrofurantoin falls under that umbrella. Your gram-positive, your community-acquired MRSAs fall under this umbrella, but this does not cover if you need tissue penetration or it's an upper urinary tract infection. This will not work, okay? So if it's pyelonephritis, remove the nitrofurantoin, not going to work. If creatinine clearance is less than 30, this is not the medication, okay? If they're pregnant, especially in their 3rd trimester, this is not the drug for them. So you see there's a few signature warning with those medications. So let's do a little bit of recap. Who owns which pathogen, okay? So this is a refresher, okay? Your beta-lactams, I'm going from bottom up, okay? That's your H influenzas, augmentin, cephalosporin. Your anaerobes, augmentin, clindamycin, and metronidazole. Your pseudomonas, ciprofloxacin, piperacillin, ceftazidime. Your community-acquired MRSAs, Bactrim, clindamycin, doxycycline. Your atypicals, macrolides, doxycycline, fluoroquinolones. Okay. Again, no cell wall, no beta-lactams. All right, so it's just a quick refresher. A couple more special ones, I want to point out to you when it comes to MRSA, okay, you must remember no beta-lactams will kill MRSA. So forget 1, 2, and 3. Mentioned that already. For MRSA, memorize Bactrim, clindamycin, doxycycline. And if they give you all 3, you're going to rule out the allergies, right? You're going to look at pregnancy. So that's how you work your way with that one. Okay, so you see purulent MRSA. Okay, non-purulent, then that's a strep one. All right, how the trap questions are built. I want to give you, paint a picture for you with that. So work the STEM in this order. I think this is how you should do it. You should look at your guidelines first, right? What's recommended, the risk factors that the client has, contraindications, the medications that they're on, then you pick your safest one. But if you're reading a question, you don't pay attention that I tell you it's a pregnant, under 18, they have myasthenia gravis diagnosed with, their creatinine is elevated, or they have chronic kidney disease, they're on warfarin Coumadin, they have a QT, like you have to pick up on these disqualifiers, okay? So that's all the teaching. Now I'm just going to practice a couple questions with you just to show you how these are phrased sometime and to also teach you, remember the APE method. So the APE method, if you're not familiar with, is very simple. It's just a 3-step method to help you answer, especially analysis level questions that require critical thinking. First thing first, you want to analyze, then prioritize, and then evaluate. So analyze is when you break down the stem of the question, right? You identify the site that this infection is in. You identify the pathogen that would be in, at that site. And you pick up on clues that we just talked about. So when you know your content, the only other thing you need to do is learn test-taking strategies. So you know your content, we've just gone over it. So if this is not, like if you feel like you don't know the content, you can always go back to this stuff, but you do need to know content. Pretty much what I've just taught you. So now that you know that, when you get a question, which we're going to practice, you're going to analyze it first. Don't just try and pull out your answer. Right? Analyze it. Ask these questions. What site? What pathogen? What disqualifies? Okay? And then you prioritize. You rank what matters. Okay? Apply your guidelines. Ask, what are the risk factors? What are the contraindications? Eliminate, right? Eliminate what for sure isn't correct. Okay, they have a sulfur allergy. We eliminate the drugs, in that category. And then you're prioritizing, what's most important. And then you're going to evaluate. You're going to choose the safest remaining options, okay? So let's go. NCLEX question number 1. The nurse is caring for a 24-year-old female client who is being treated for a urinary tract infection. The client now reports flank pain, fever, and costovertebral angle tenderness, CVA tenderness, okay? So let's analyze this question. I see flank pain, fever, CVA tenderness. I say to myself, this is not a lower or uncomplicated UTI, okay? Fever, right? That rules out an uncomplicated UTI. So I need something that is going to penetrate that tissue. Okay, this is not a simple cystitis. So I'm processing that as I'm reading this. Okay, so I need the drug to be able to reach the kidneys. I'm saying that to myself because this is not a lower. Okay, this is an upper. So I need to choose a drug that's going to climb up there. And from my knowledge, I know that macrobid, right, nitrofurantoin, concentrates in the urine only. It has no tissue penetration, so I'm going to remove that. And look at my stem, the part of the question that asks the question, right? So answer the question, which of the following prescription should the nurse question? Just me analyzing the question and answering these questions, in my mind, I get to the correct answer. I haven't even looked at my options, folks. This is how you do this. I don't even look at your options. You need to analyze the question first. And when you know your content, you're able to do that. So I'm reading this. They're 24-year-olds, so I'm not worried about age, okay? They're being treated for UTI, but now they're reporting all of it. That tells me might have started with a lower UTI, but we're past that. This is upper now. And I say to myself, okay, I need something that is going to reach the upper track. So, and then I look at this, which of the following prescriptions should the nurse question? I'm going to question the drug that will not do that. You see how easy? First of all, knowing content and then analyzing my question. Okay? You can do the rest too, right? Evaluating. So I'm going to look at the others. Yeah, Cipro is fine. Rocephin is fine. Bactrim is fine. Nothing tells me there's, allergies that would rule out the others. No age that would, yeah. So that's how you answer a question like this. Okay? Analyzing the flank pain, the fever, the CVA tenderness tells me this is an upper. Number 2, prioritizing. The drug must reach the kidneys and nitrofurantoin does not. And the question is asking me which one would I question? That's the one I would question because it would not work to treat this upper urinary tract infection. Okay. The others are appropriate. So this was what we would call a nitrofurantoin trap. All right, let's try another one. The nurse is reviewing the plan of care for a 30-year-old client who has been diagnosed with atypical pneumonia caused by Mycoplasma pneumoniae. Okay, which of the following classes of antibiotics would be ineffective for this client? Okay, you see how I emphasize on the ineffective? Because if you're reading this too fast and you don't pick up that you're looking for the ineffective, then you're heading down the wrong neighborhood to begin with, okay? All right, so let's analyze. Mycoplasma is an atypical, it tells you in the question anyway, is an atypical pathogen, okay? No cell wall. So you should not be choosing, okay, any penicillins, augmentin, or separate. You see how now it's like, hopefully you're doing that. You're going, all right. So that alone helps you to, eliminate, based on the options they put here. So no cell wall. All right. So we're going, that's me analyzing the question, okay, before I even look at the answers. Okay. So ineffective. So I need to pick the thing here that would not work. Okay. And what would not work, remember 1, 2, and 3. Those are your penicillins, augmentins, and cephalosporins. Ineffective. So I'm looking for what here would not work. Okay. So your penicillins and your cephalosporins and augmentin would not work here. Okay. So that's how you do a question like that. Your beta-lactams are not effective with atypical. Okay. The others are fine. Yep. Any of the 4, 5, 6, 7s would work. Okay. All right. One more, well, a couple more. So let's see. The nurse is caring for a client who has a purulent cellulitis with a fluctuant abscess and reports a sulfa allergy. Incision and drainage has been performed. Which of the following oral antibiotic prescriptions should the nurse anticipate to cover community-acquired methicillin-resistant Staphylococcus aureus? Great question. All right, so we already know it's MRSA, but even if they didn't tell you it's MRSA, purulent cellulitis is MRSA. Okay, so prioritizing. So I am going through my head in my cascade, and I know what's not going to work in killing MRSA. Okay? So forget your penicillins, your augmentins, and your cephalosporins. Remember, we just said they don't kill MRSA. There is no beta-lactam, okay, that covers MRSA. They just don't. So eliminate them. So you're going to go through your list, okay, and you're going to get rid of those medications. They will not work. Cephalexin, that's a cephalosporin, get rid of it. Amoxicillin is a penicillin, get rid of it. Okay, and if you missed that they had a sulfur allergy, you're in trouble. You've got to pick up on those clues. That's what eliminates option number 4. And that leaves you with 3 as your correct answer. And because you should memorize, BCD, okay, which I mentioned earlier, you should memorize that, okay? But they're allergic to Bactrim, so that can't be the answer. Okay, so you see a combination of you knowing your content and you having test-taking strategies is brilliant. All right, one more. The nurse is caring for a 68-year-old client who has chronic kidney disease. You've got to process that. This is me analyzing even before I'm done answering the question. They have chronic kidney disease and they take lisinopril, okay? ACE inhibitor, right? Remember prils? They take Zestril. The client has developed an uncomplicated UTI. Awesome. Okay, tells you, don't miss that un. If you miss that un part, you see one little word, not even the full word, the prefix of the word, have you going in a different direction, okay, or the right direction if you pick up on it. Okay, so the guideline first for uncomplete. First, let's finish the stem. Which of the following prescriptions should the nurse question? You're questioning it, okay? So you're looking for the wrong one. So do that. So the guidelines first for uncomplicated UTI we know is Bactrim, but this client has chronic kidney disease and they are on an ACE inhibitor, right? We're processing all of that, okay? Yes, it's an uncomplicated UTI, great, but that history I just gave you was not because I felt like, or I threw a dart. No, you need to process that they have chronic kidney disease and that they're on an ACE inhibitors. Okay, so Bactrim, like I mentioned earlier, causes hyperkalemia, okay, and raises your creatinine. So they're on an ACE inhibitor, okay? So that compounded, your hyperkalemia, your creatinine compounded by your ACE inhibitor, what are we going to do to the kidneys, right? So you have to process that renal function. What's going to be the effect of that? So we're going to question that Bactrim, even though we know, first line for uncomplicated. So we're going to go for a safer agent. Okay, so that's our question here. What here is safer, okay, for this client for the uncomplicated UTI? Is it cephalexin, fosfomycin, or augmentin? Okay, so now what you should do is go down your cascade. Okay, and the first one in your ladder or your cascade, whatever terminology you want to use, is augmentin. And it's the right dose, 875 over 125 milligrams orally twice a day. Yep, that would be your best option there. Okay. Let's go back. Hold on, we're questioning this one. Oh, you see, I had to go back. Oh, I did this. Yeah. Okay. So yeah, we're questioning the Bactrim, but the option you would choose, to give the client would be your augmentin, but question the Bactrim because of the Aspril. So I just made up another question in my mind. So if I were to switch this from, questioning to the best medication here, then it would be the augmentin. But the question is asking us what we're questioning. We're questioning the Bactrim. Okay, so we're going to question that. The safer drug would be your cephalexin, and then your augmentin, and then your phosphomycin. They're all appropriate. But if there's no allergy to penicillin, I would go with the augmentin first. And then if there's an issue, with that, then I would go with the cephalexin. Some providers may do the opposite. But yeah, so great question. And I see another question within that question by just changing the stem. Pretty cool. Let's see what else crossed my mind. Okay, yeah. So let's try one more, and then I'll just remind you of some things. All right, the nurse is caring for a 16-year-old client who is a competitive runner, has a history of tendon injury, right? A true question. This is such a awesome NCLEX-style questions. I'm not telling you that just because. You have to process. There's a history of tendon injury. So certain medications already have to be crossing your mind. They have a documented anaphylaxis reaction to penicillin. That's another thing, you're going to get rid of anything penicillin, even before you look at your answers. The client is diagnosed with acute bacterial rhinosinusitis. So which of the following questions should the nurse question? And I do these negative query stems on purpose, right? They help you think and process. So these are purposeful, okay? So analyze. So first of all, I'm looking for the wrong option here because I'm questioning it, right? So I have some disqualifiers. You have to process these. They're 16 years old. That's a disqualifier. Pick up on the age. And they have a history of tendon injury. That's another disqualifier. A third one is that reaction. Okay, and they tell you that it is an anaphylactic reaction, right? So we're not even going to go to the cousins. Okay. So that's all great. So let's eliminate. That's pretty much, what we need to do here. We need to eliminate options. Okay. Well, since we're doing what we should question, let's take a look at, what's fine here. So you could do this either way. You could, anything that's fine is not the correct answer because we're looking for something we should eliminate. Or you could go, right to it, but never just choose one and not look at the others, okay? So for time purposes, we'll do that sometimes, but for you're studying, you're, prepping, you want to always look at every option. All right, so we're going to, question the Levaquin, definitely because of the age and because of the tendon injury, for sure. Okay, so yeah, we're gonna question that. There's no reason they couldn't do the doxy. Yeah, I don't see anything here that disqualifies them. There's nothing with the cardiac, issue if that were there. But the others are fine. Let's look at azithromycin. That's not a penicillin. Clindamycin, that's not a penicillin. The allergy is with penicillin. But we could have easily throw penicillin in there, right? And see if you're processing that. So another really good question. Okay, so we would question the Levaquin because of the tendon injury. We would question that because of the age. Yep, number of reasons that rule this one out. All right, so let's go over the whole method in just these lines. You need to learn the 8 classes, not hundreds of medications. The site predicts the pathogen. Where is this pathogen? Okay, and then the pathogen picks the drug. It's just that simple. No cell wall, no beta-lactam. Atypicals, macrolides, doxies. Okay, then your fluoroquinolones. No beta-lactam covers MRSA, so no 1, 2, or 3s on our list. Community-acquired MRSA belongs to Bactrim, clindamycin, and doxycycline, and you're gonna remove one or the other based on, allergies or disqualifiers. Penetration matters. So if it's a lower bladder, then your nitrofurantoin is fine unless there's another contraindication. If it's higher, like pyelonephritis or prostatitis, you need something that penetrates the tissue for those. So microbid would not work. Hold fluoroquinolones, okay, for your last resort. There are many other drugs that will work great without all the side effects, adverse effects. So weigh your pro and your con. Okay, always look at your disqualifiers. How old are they? Are they pregnant? Do I have a QT, prolongation? Like what's going on with this client? So that is antibiotics, ladies and gentlemen. All right, so that is everything. So I pray that this was helpful. Do reach out if you have any questions or, concerns. Again, save this and watch it again and again. The one time is not sufficient. And I probably should have even gone into more details and naming the drugs for those of you who are, looking at this or listening to this rather while multitasking. But you could always listen to it again and again and again. All right. Have a wonderful day, everyone. God bless.